I want you to close your eyes for a second and just picture an emergency room.
All right.
It's a Friday night.
Oh.
It is, it's chaotic, fluorescent lights humming, monitors beeping everywhere. You hear gurneys rattling down the hall.
I can picture it.
And a patient is wheeled in. Let's say they've got sudden slurred speech. Maybe one side of their face is drooping. Everyone is moving so fast because in this scenario, the clock isn't just ticking, it's screaming.
The classic time is brains scenario. Every minute matters.
Exactly. Now, I always assumed the bottleneck in this situation was purely physical. Waiting for the massive MRI machine to be free.
Or for a porter to be available, yeah.
But I've been reading this new study you sent over, and it turns out there's this invisible, almost intellectual step that happens before the patient even gets near the machine.
It is invisible to the patient, and frankly, it's invisible to most hospital administrators.
But not to the doctors.
Oh, to the radiologists, it is painfully visible. It's called protocoling.
Protocoling. It sounds so formal, like something you do at a diplomatic dinner.
Uh-huh.
But today's deep dive is all about this one high-stakes bottleneck. We are looking at a really fascinating study from Radiology, artificial intelligence. And the question they're asking is straight out of science fiction.
It really is.
Can we train a chatbot, specifically a large language model like GPT-3.5, to take over this job? Can a machine be the traffic controller for the human brain?
And the study isn't just a what if, it's a showdown. They pit the old school models against the new generative AI.
And then against people.
And then, just to make it interesting, they pit all the AI against actual experienced human doctors.
Man versus machine versus older machine. I love it.
Precisely. And the results.
Yeah.
They honestly challenge how we think about expertise, language, and, well, the future of the hospital itself.
Okay, so before we get to who won this showdown, we have to understand the game. Let's go back to that protocoling bottleneck. I want to unpack this because I think most people, like me, assume an MRI is like a camera. You just point it and click. The ER doctor types, patient has slurred speech, and hits send. Why can't the MRI tech just push the brain scan button?
Because there is no single brain scan button. That's the core misconception. An MRI is this. Incredibly versatile, complex beast of physics.
Okay.
You can tune the magnetic pulses, the timing, the frequencies to highlight completely different types of tissue.
So that note the ER doc typed.
It goes to a radiologist, a highly trained doctor who is probably in the middle of reading a complex cancer scan.
So they're already busy.
Extremely. They have to stop what they're doing, switch tasks completely, read your messy, hurried note, and translate that clinical clue into a technical instruction. They have to decide how to scan the brain.
So they have to interpret slurred speech and think, okay, we're looking for a clot, not a tumor.
Right. And in this study, they identified 12 distinct protocol classes. You have a stroke protocol, a tumor protocol, an epilepsy protocol, infection, trauma.
The list goes on.
It does. And each one changes the angles, the slice thickness, the whole physics of the scan.
And if you get it wrong.
If you pick the epilepsy protocol, when the patient actually has a brain tumor, you might just miss the tumor.
Yeah.
Or, you catch it, but the image is so bad you have to bring the patient back and scan them all over again.
That's terrifying. So this is a diagnostic decision before the diagnosis even happens.
It's a critical gateway decision, and there's a second layer to it. It's not just how to scan, but whether to use contrast.
The dye. I've had that. Makes you feel warm all over.
Yes, usually a gadolinium-based dye. It lights up blood vessels, shows you where the blood-brain barrier is broken, essential for seeing things like active tumors or infections.
But you don't want to use it if you don't have to.
Well, it adds cost, it adds time, and while it's generally safe, there are small risks. So the radiologist has to make 2 high-stakes calls from just a few words of text.
Which of the 12 protocols? And contrast, yes or no?
And they are doing this constantly. The study estimates this task eats up about 3.5% to over 6% of a radiologist's total working hours.
That sounds small as a percentage, but in practice.
It's huge. That's hours of lost time every week for every doctor. And it's the context switching. Every time they stop to protocol a request, they lose their focus.
It's like trying to write a thesis while someone texts you every 10 minutes to ask what's for dinner.
That's a perfect analogy. And because the senior brain experts are so busy, this job often rolls downhill to residents or general radiologists. They're tired, they're interrupted. It's a perfect storm for errors.
So the researchers in Finland said, let's see if the robots can handle the dinner orders. Let's talk about the data they used. Because this was real-world, messy stuff.
Absolutely. They pulled nearly 2,000 emergency brain MRI referrals from the hospital archives. from 2016 to 2019. And here's the curveball that makes this study so important.
What's that?
The notes are in Finnish.
I was going to ask about that. Does the language matter that much?
You'd be surprised. Finnish is notoriously difficult for computers. It's what linguists call an agglutinative language.
Agglutinative.
Yeah.
Sounds sticky.
It is. It means they glue words together to create meaning. In English, we say in the house. 3 words.
Right.
In Finnish, they might just take the word for house and add a suffix to it to mean the same thing. You get these long, complex, compound words.
Which has to be a nightmare for a computer trying to break down a sentence.
Immensely. And remember, these are hurried notes from stressed ER docs at 3 a.m., typos, slang, abbreviations. The average note was only about 50 words long.
So the AI has to decipher a misspelled 50-word cryptic message in a complex language and make a life-or-death decision.
That's the challenge. If you can solve it in Finnish, you can probably solve it anywhere.
Okay, so how do we know who got it right? Who's the referee in this match?
This is a crucial point in any AI study establishing the ground truth. So they brought in the heavy hitters, 2 expert neuroradiologists with 12 and 16 years of experience.
The ultimate authority.
Yes. They sat down and reviewed every single one of those cases and determined this is exactly how this patient should have been scanned.
They're the gold standard,
Yeah.
the Supreme Court of MRI protocols.
Exactly. Everything else, the AIs and the other humans, is measured against their decisions.
All right, let's meet the contenders. In the blue corner, we have the old school tech. What are we looking at there?
These are the machine learning models we've relied on for the last decade. Things like naive Bayes, support vector machines, SVM, and XGBoost.
XGBoost. Sounds like an energy drink for gamers.
It does, doesn't it? But these models generally work by, let's call it statistical counting. They use a bag of words approach.
Bag of words.
Imagine taking a sentence, cutting out every word, throwing them in a bag, and shaking it up. The model just counts them. It doesn't know the dog bit the man is different from the man bit the dog.
So if the word bleed is in the bag, the probability of trauma protocol goes way up.
Correct. It's just pattern matching. It doesn't understand context. If you wrote no bleed, it might still just see the word bleed and get confused.
Got it. And in the red corner, the new school. This is where the hype is.
Right. Here we have the deep learning models. First, there's BERT, specifically FinBERT, pre-trained on huge amounts of Finnish text. BERT is smarter. It looks at words in context.
And then the heavyweight champion.
GPT-3.5 Turbo, the engine behind the ChatGPT that took over the world. It has read, basically the entire internet. It understands nuance and medical reasoning in a way that other models just can't.
It's not just counting words.
It's building a mental model of what the text actually means.
But the researchers didn't stop there. They added a third contender, humans.
Yes, and this is maybe the most important part of the study. They got 2 experienced emergency radiologists. These are the people who actually do this job every day.
So the setup is, can the AI beat the old models? And, more importantly, can the AI beat the human generalist doing the job right now?
Let's look at the results. They started with the hardest task, picking the correct protocol out of those 12 options.
And who won?
GPT-3.5. It took the gold medal. Trained on the full data set, it hit 84% accuracy.
84%. Now, without context, that sounds
Okay.
like a B- on a test.
Right. But in medicine, on a task this complex, 84% is huge. And here is the context that matters. The human radiologists.
The profession.
They scored between 80% and 83%.
Wait. Pause. The chatbot beat the doctors.
It statistically outperformed one and tied with the other. So, effectively, yes. The AI performed at a specialist level, even slightly better than the competent humans who do this for a living.
That is startling. I mean, we hear about AI potential, but to see it in a head-to-head on their own turf?
Wow, how did the old school models do?
Respectable, but a clear tier below. BERT scored 78%. XGBoost, the best of the old guard, also hit 78%. So you see the hierarchy.
Statistical models are good, humans are better, and GPT 3.5 is at the top. What about the contrast die decision? Yes or no?
It's a simpler binary choice, so everyone scored higher, but the pattern held. GPT 3.5 hit 91% accuracy.
And the humans.
Right there with it, scoring between 89% and 91%.
So on the easy question, it's a tie. On the hard question, the AI edges ahead. I want to dig into why. What makes GPT 3.5 so much better? The researchers did a really clever experiment to find the answer. They decided to starve the models.
What is that, Mark?
They cut the training data in half. They wanted to see what happens when you only show the AI a small number of examples.
Like trying to learn a language with half a textbook.
Exactly. When they did this, the performance of BERT and the older models just fell off a cliff. BERT dropped from 78% down to 69%.
In GPT.
GPT-3.5 barely flinched. On that small dataset, it still scored 82%.
That's incredible. It lost almost no accuracy.
This is what we call few-shot learning. Because GPT 3.5 already has this massive general understanding of language and medicine, it doesn't need to see 500 examples of a tumor referral.
It can generalize from just a few.
Right, and that's critical in medicine where data for rare diseases is, incredibly scarce.
And unbalanced. You mentioned in this study nearly half of all referrals were for stroke.
46.6% were for stroke, so any model can just guess stroke and be right almost half the time.
The lazy student strategy.
Exactly, but the real test is the rare stuff. There were categories like sella or internal auditory canal.
Sella. I have to admit, I don't know where my sella is.
It's the sella turcica, a tiny saddle-shaped bone in your skull where the pituitary gland sits. It's deep in there. You need a very specific scan to see it properly.
And a general stroke scan would miss that completely.
Totally. The old models struggle with that because they just haven't seen enough examples. But GPT knows what a pituitary gland is from its general training. It sees hormonal imbalance in the note, connects the dots to sella. That ability to handle the long tail of rare diseases is what separates it.
There's one other number we have to talk about. Not just accuracy, but time.
The workflow revolution, yes. The researchers tracked how long it took the humans to review the test set of 390 referrals.
How long?
It took them between 5 and 6 hours of concentrated work.
That's nearly a full workday. And the AI.
Seconds to minutes.
Okay, pause on that. We're talking about giving a doctor 6 hours of their week back. That's not just efficiency. That's preventing burnout.
It's massive. We call it cognitive offloading. The idea isn't that the doctor goes home early. It's that instead of starting from scratch, they are presented with a draft. The AI says, I think this is a stroke protocol. Approve.
It changes the task from decide to verify.
And that turns a 2-minute distraction into a 10-second check.
So GPT 3.5 is accurate, it handles rare cases, it's lightning fast, and it speaks Finnish. It sounds like a slam dunk. Why aren't we installing this in every hospital tomorrow?
Well, here's where it gets complicated. There is a massive but in this study, and it's not technical, it's legal.
Let me guess. Privacy.
Bingo.
Yeah.
To use GPT 3.5, you have to send the data, the patient's referral note, out of the hospital through an API to OpenAI's servers.
Which are probably not in Finland.
Probably in the United States. And European privacy laws like GDPR have a lot to say about sending Sven's medical records to a U.S. tech company.
And most of what they say is no.
Exactly. For routine care, it's a non-starter. You can't just pipe identifiable health data into a commercial cloud service.
So we have a Ferrari engine, but we can't legally drive it on the road.
That's a great analogy. This is the cloud versus local debate. The other models, BERT, XGBoost, they're open source. You can run them on a computer in the hospital basement. No data ever leaves.
But they aren't as smart. BERT only got 78%.
True. But is 78% useless? Or is it good enough?
That's the question. If the human is at 80% and the local private AI is at 78%, that's a really small gap.
Right. And maybe the best approach is a hybrid one. You use the local secure model to triage all the easy stuff with high confidence.
And then the humans only have to deal with the tricky 30%.
Right. Or we wait a year or two for the powerful open source models, the ones that can run locally, to catch up. And they're catching up fast.
There was one other finding I found oddly reassuring.
Yeah.
When the AI got it wrong.
Why? Garbage in, garbage out. The researchers noted that many of the errors happened when the referral note itself was terrible.
Like just one word.
Yeah. Referrals that just said vertigo or dizziness.
Which, to be fair, could be anything.
It could be a stroke, a tumor, an ear infection. The study noted that even the human radiologists struggled with these. It wasn't that the AI was stupid, the situation was just ambiguous.
That's comforting. It's failing exactly where a human would fail when there isn't enough information.
It highlights that AI isn't magic. It can only read the doctor's note.
Okay, so pulling this all together, we have AI that can read complex medical notes in a foreign language, as well as a human specialist. It's faster, but it's stuck behind a privacy wall for now. What's the big takeaway?
It matters because it signals a tipping point. For years, we've heard AI will revolutionize medicine, but it's often been hype. This is peer-reviewed proof that the tech can handle these unstructured language tasks.
It's moving from just seeing pixels to thinking about words.
In a limited way, yes, and the goal isn't to replace the doctor. I want to be clear on that. The goal is to stop the interruptions.
And those 6 hours we talked about.
If we can save that radiologist 6 hours of administrative work, that is 6 hours they can spend diagnosing patients, that reduces waiting lists. That saves brains.
It's efficiency that translates directly to patient safety.
Exactly.
Before we wrap up, I want to leave our listeners with a thought that really stuck with me. We talked about the reference standard, those 2 super expert neuroradiologists who decided the truth.
The Supreme Court.
Right. But the study also showed that the other experienced radiologists, the humans in the control group, only agreed with those experts about 80% of the time.
That is a profound observation. It's kind of the dirty secret of medicine.
It means that even among highly trained humans, there is a nearly 20% disagreement rate on what the right thing to do is.
We hold AI to this standard of perfection, 100% accuracy. But the ground truth itself is fuzzy. Medicine isn't math.
So if 2 brilliant doctors can't agree 1 out of 5 times, is it even possible for an AI to be 100% correct?
And if we do deploy these systems, if the AI becomes the standard, what happens to that human disagreement? Do we flatten out all that nuance?
That's the fear.
If a resident spends their whole training just clicking approve on what the AI suggests, do they ever develop the deep intuition to know when the AI is wrong?
Do we de-skill the workforce? Are we training a generation of doctors who know how to verify, but not how to decide?
That's the question for the next decade of medical education. We might solve the bottleneck, but we have to be careful not to lose the expertise that built the bottle in the first place.
A scary and fascinating thought to end on. If the machine becomes the expert, we'd better make sure we don't forget how to double-check its homework.
Absolutely.
Well, that's it for this deep dive. We hope you learned something new about what's happening behind the scenes at the hospital.
Thanks for listening.
See you next time.